Welcome to a recent interview that I shared with a local alternative care practitioner, Todd LeCesne, who I really think of as an absolute futurist. That is someone that's taking full advantage of the synergistic potential of conventional healthcare and cannabis therapy. I hope you enjoy.
And that gets me back to why I'm here. I'm here because, to me, we're at the very front of all this. And it's an exciting time to be part of something that seems to be new. It's not at all new. It's been around for thousands and thousands of years. We're just now dusting it off. I heard this the other day, if we wear our clothes, and hang these things in the closet long enough, you can eventually take them out and this will be back in style.
Okay.
This cannabis is back in style. It's been around for thousands and thousands of years. It's not new at all. It's our acceptance to it. And I think the marketing of it, that's become a little bit new, and society's acceptance of it that's new. And those things are super exciting for me.
Sure. So what I'm hearing is, just like in the case of news, we sometimes have to look for alternative sources to educate ourselves in this, particularly in this arena. Now, I know that one of the sticking points for a lot of novice cannabis users is the point that they don't want to get high. Mm-hmm. And this is something that's really important to them. I sometimes talk about this, on the camera and to my classes and lectures and so forth, in that really, what are we talking about with regard to getting high? We're talking about a visceral sense of well-being or pleasantness or subjective well-being. So you could use other types of jargon terms, which are essentially the missions of our pharmaceutical applications and the missions of our provisioning in terms of general health care and so forth. But this seems to be another case where the term has been created as a pejorative and specifically tailored for cannabis. So getting stoned, doped, high, and so forth, these are all negative terms. All of us would assume are negative. But it's something that is so ingrained, particularly for older patients, that is oftentimes very hard for them to get over or accept that it's even a good thing.
Sure. So luckily, and you're right, there's some stigma around that, obviously. And really what I'm hearing there is a lack of knowledge, a lack of education. And it's an opportunity for us to do some discussions with the patient to let them know that there are options for you to not have to feel a way that you would perceive to be a negative. So the way that I talk about this with patients too is back in the day, there was a medicine called amitriptyline, tricyclic antidepressant. Amitriptyline was drug of choice back in the 70s to treat depression. We couldn't use that in the 80s and so forth because society was a little bit too in motion and needed to move forward a little bit. And the number one side effect using a tricyclic antidepressant is it prolongs the QT interval on the heart wave and can predispose you to arrhythmias. The other thing from a patient's perspective, and by the way, interacted with a lot of medications. From the patient's perspective, the number one side effect of that was made people sleepy, so you can't take that thing during the day and actually go to work. That began a class of medications called the SSRIs, the serotonin selective reuptake inhibitors. And this particular class of medications interfered or helped to stop a specific neurotransmitter, serotonin, from being reabsorbed and then promoting feelings of depression and downward despair, et cetera, et cetera. And we developed the SSRI classes because you could take that medicine at 9 o'clock in the morning and not have it affect your drowsiness and your wakefulness during the day. It was an improvement on amitriptyline from back when, and the tricyclics from back when. The medication then evolves one step further because another side effect of the SSRI classes is it created anorgasmia or impotence for men. And so now we have to do another evolution of that medication. We developed the SNRI classes that targets another neurotransmitter, norepinephrine, instead of serotonin. And now this medication doesn't cause that harmful side effect and so forth. And you see a progression in how medications have evolved over years. Such is true with cannabis. Cannabis nowadays can be genetically engineered to take the non-desirable molecule away from that medication and give you just the therapeutic molecule if you so desire. We've identified the different constituents within that plant in 3 different versions of this. So we have, the phytocannabinoids, we have the endogenous cannabinoids, and then we have synthetic cannabinoids. So endogenous cannabinoids are things that your body makes on its own. Happen to be 2 that we've identified, 2-AG and an anandamide. We have the phytocannabinoids, which are the plant-based cannabinoids, which is cannabis, which might contain cannabidiol, the number one molecule, along with tetrahydrocannabinol, which is THC, which is the psychoactive component to the plant. And then we have synthetic cannabinoids, which are the cannabinoids that are based on the plant-based cannabinoids, which are now the pharmaceutically created cannabinoids, something like dronabinol and these other medications that are now FDA approved, Epidiolex, that we can use on the pharmaceutical side of the discussion also. But the interesting thing about the cannabinoids, again, back to the initial discussion over here, is that we can, just like alcohol, for example, can give you a non-alcoholic beer that looks like beer, that tastes like beer, that smells like beer, but doesn't give you the intoxicating effect of beer. We can do that with the cannabis-based therapies also. So we also have evolved the mode of administration of that medication so that you don't have to combust this material anymore and smoke it. There are edibles, there are tinctures, there are topical rubs, there are cannabis-infused fabrics and masks and things that we could use on the skin that are absorbed topically. There are liquids that you can ingest. Those ingestions also come with different micro-encapsulations and different mechanisms within the drug itself that increase the bioavailability of that drug and make it more likely that you can absorb it and your body can actually use it. So the cool thing about that is the milligram dose comes down, mm-hmm. the affordability goes up for a patient as well because you use less of the product. All sorts of new things have come into the space that's super exciting for me as a clinician. Again, in that tool bag, so many options for the patient. One of the things that we're really promoting in our clinic for patients when we start cannabis-based therapies is the same thing that we do in pharmacology is the old adage of start low and go slow.
Sure.
We want for the patient to have a good positive experience. A positive experience is an experience where you have maybe no experience on the first occasion when you use that, or even the second or the third, because I think that worst case scenario is a patient who comes in and takes something, maybe they got it from a family member or something like that, and got it in a dose that wasn't sufficient for them. The prototypical example would be an edible. They take a bite of this particular chocolate or a gummy bear. They say 10 minutes into it, hey, I don't really feel anything. They pop the whole thing in there. And then an hour from now, they're like, holy smokes, I'm under the influence. How do you turn this thing off? I've been in Loveless emergency room on a couple occasions when people have, quote unquote, overdosed on cannabis. Yeah. Well, from our side of the desk in an emergency department, we're going to do a vital signs. We're going to plug you in and check your regular vital signs. And then we're going to sit you right over there in the observation room. And we're going to give you an orange juice and crackers and a peanut butter because that's all that's available in an ED anyway. Mm-hmm. And every once in a while, people just peek in to see, hey, is he ready to leave yet? Right. That's the extent of the intervention that we would do in the case of cannabis toxicity, or not toxicity, a cannabis overdose or overindulgence. Sure. And a lot of that has to do with just the education, and start low and go slow, and educate a person on how to kind of move things forward. Another principle of administration of the cannabis therapies is we advocate for small doses of multiple things over a 24-hour period as opposed to a big dose on one or two occasions or so. Okay. So maybe patients do well with a couple drops of tincture, with a topical, with a small dose of an edible, with an inhaled product or so. If you're having an episode of anxiety and it's really bad right now, an inhaled route is the most effective thing that with the shortest onset of action and the most rapid effect for you and so forth. So the current thinking is microdosing of multiple classes of medication in small dose frequently throughout the day to continue to massage the endocannabinoid system, keep that system revved up. You're more likely to get a good effect that way and less likely to experience any adverse effect from any one of those particular doses during the day. So a whole lot of dosing considerations. And the last thing I would add to that is there's not a whole lot of reproducibility of how we do it for each patient. Mm-hmm. It's difficult because patients sometimes come in and referred to as cannabis naive. They've never tried anything. Other patients remember what it was when we were in high school or in college and haven't used anything for XYZ length of time. Some people are slow users at the concert every once in a while, and their knowledge of what this feels like and their willingness to accept a feeling of being a little different than it was before might be a little bit more receptive to that. So a whole lot of different dosing considerations that need to come into play. And that's where it's important to have somebody who specializes in cannabis-based therapies, who knows how to ask those questions during the history to really be able to inform where we start, how we might start. And then the other thing is that I don't get to decide any of it. I present options. I present options for the patient. I want to say, hey, Mr. Vigil, here's what I think might be helpful for you for that particular situation. And there is laws and regulations with regards to what type of claims I can even make with regards to these products, because these are non-FDA approved products. These are nutritional supplements, etc. And so there's specific language that has to go in a practice with regards to how we talk about utilizing these therapies, because we can't make medical claims on some of them. An interesting thing that we're seeing in the market space nowadays too is a lot of the manufacturers are adding things to their cannabis-based therapies. For example, curcumin, which is an anti-inflammatory. You see that often with turmeric or arnica, and you could put those in a eutetic mixture and create a salve. And when it says turmeric and it says arnica or it says menthol, eucalyptus, and things like that on the label, now collectively I can talk about that hemp-based product or that cannabidiol-based product as having anti-inflammatory activity, because I'm referring to the ones that FDA has actually approved that says that it's okay for you to call this an anti-inflammatory. And it's a really cool marketing thing. I can talk about it now appropriately because I'm not necessarily referring to the therapy that doesn't yet have the full blessings of the FDA.
Sure.
So that's an important component too.
Thank you for watching this part of our interview. We truly hope that it helps as many people as possible, including some of you practitioners out there that are still open-minded and want to be able to utilize as many tools and resources as possible to continue to enhance the well-being of your patients. If you appreciate the content that we're bringing you nearly every single day, please consider hitting the like and subscribe buttons or sharing these videos with your friends and family. Consider becoming a Patreon to this channel or even a donor to the University of New Mexico Medical Cannabis Research Fund, where we are working very hard conducting cutting-edge research every single day, using all kinds of different types of research designs, working with humans, animals, large data sets. We do it all, and we're working really hard essentially to improve the well-being of our community. Through these efforts, collectively, together, we're starting to feel it. We're changing the world.